All right. Hello, everyone. My name is Dr. Shenava. I'm one of the physicians at the pain clinic. I think I've met most people here for the most part. I go by Shanu, preferably it's my nickname. We'll be talking about opiate pain management. It's kind of a hot topic of late, kind of been in the news and things like that. And the CDC and the DEA have put out like a joint kind of guidelines based on some evidence with regards to the practice of pain management and opiate management specifically. So I'm not sure if anyone knows who this is outside of the pain clinic. This is Yes, exactly. This is Dr. I didn't expect anyone to know that. This is Dr. Lisa Tseng, 46-year-old general practitioner from LA, who was actually convicted of murder, 3 counts of murder for her patients who overdosed on opiate medications. So this is kind of a landmark case because of the fact that it was a murder conviction, not like malpractice, not negligence. So it's being called kind of like a landmark case. So next, the guidelines. What does it actually address? Number 1, when obviously to initiate or continue opiates for chronic pain. 2, the selection, dosage, and duration of follow-up, as well as the discontinuation of opiates. And then, of course, assessing risk and addressing harms associated with opiate use. Chronic pain, what is it? Definitionally, loosely, it's defined as pain that lasts more than or equal to 3 months. Past the time of normal tissue healing is basically what that is. Although minimum duration of symptoms was not specified, between 2003 and 2007, approximately 43% of adults in the United States were shown to have some form of chronic musculoskeletal pain. Acute pain is, of course, the inverse, less than 3 months. Evidence does support that short-term efficacy of opiates for reducing pain does improve function in non-cancer patients, essentially. However, there's less studies, less evidence that opiate use for more than 3 months improves outcomes. So in a nutshell, evidence supports improved outcomes, better functioning in short term, but not necessarily in long term. But again, evidence is not that great for the latter. Just some opiate-related facts. In 2012, healthcare providers provided 259 million prescriptions for opiate pain medication. That's approximately enough for every adult in the United States to have a bottle of pills. Opiate pain medication use presents serious risks, including overdose. There's been 165,000 persons die of overdose related to opiates in about 15 years period. A recent study of patients aged between 15 and 64 years receiving opiates for chronic non-cancer pain and followed up to 13 years revealed that 1 in 550 patients died from opiate-related overdose at a median of about 2.5 years from their first prescription. In 32 patients who escalated to opiate overdoses, over 200 morphine milligram equivalents died from opiate-related overdose. I'll go over what morphine milligram equivalents and that definition in option. So morphine milligram equivalents, this is just basically, regardless of the opiate you're on, this kind of just helps convert to how much morphine that equals. So for example, you've got hydrocodone, which is our most commonly prescribed opiate medication, which is in Norco. It's basically a 1-to-1 ratio with morphine. So if a patient is on, say, like 4 Norco 10s a day for pain, that's 40 milligrams of hydrocodone, which is equivalent to 40 milligrams of morphine. And then some other medications there as well. So the methodology that they use is kind of complex, and I'm not going to get into all that now. Just basically what they did to kind of help guide them for putting out these guidelines was basically posing 5 questions, getting to the answers to these questions, and using whatever evidence they did have. And to preface that, they only had type 3 and type 4 evidence, which again is considered limited or severely limited. So again, the evidence is not necessarily strong for these recommendations, but they utilize expert opinions as well as the evidence that they did have. Question 1 was just the effectiveness. Again, this is long-term versus short-term usage of opiates versus placebo versus non-opiates, harms, dosing strategies, risk assessment and mitigation, and then of course effects of opiate therapy on acute pain when a person has already been in chronic. So there's 12 recommendations. This is the first one. I'll just read that, and then I'll just read a couple, and then I'll just tell you a couple of points about each recommendation. Non-pharmacological therapy and non-opiate pharmacological therapy are preferred for chronic pain. Clinicians should consider opiate therapy only if the expected benefits for both pain and function are anticipated to outweigh the risks to the patient. If opiates are used, they should be combined with non-pharmacologic therapy and non-opiate pharmacological therapy. So what does all of this mean? Basically, they're saying that you need to use, or that it's preferred to use multiple ways, multiple methods to treat pain, not just opiates, in order to relieve, maximal pain relief of pain symptoms. Basically, they're not saying that opiates don't have a role, but it can't be the only role. You have to try other things to try to help with their pain. What they found the best evidence for having benefit was two things. One was, of course, physical therapy and exercise therapy, which can help reduce pain, improve function for chronic low back pain, osteoarthritis of the hip and back, as well as fibromyalgia. Secondly, the next most important thing with evidence-based proof was cognitive behavioral therapy. This helps patients to train themselves in behavioral techniques, helps patients modify situational factors of the cognitive process associated with chronic pain.
Now, when they said physical therapy, they meant manipulative therapy as well, right?
Yes.
Chiropractic.
Yes. It was kind of a side note, but they included it in there with chiropractic. Non-opiate pharmacological therapies. Acetaminophen is actually the drug of choice for osteoarthritis pain per the guidelines and per the CDC. NSAIDs are also considered first line. However, you have to be careful, of course, of patients who are elderly or who have kidney or gastric bleeding disorders or anything like that. Neuropathic pain drugs for radiculopathic, neuropathic type pain, first line drugs were like anticonvulsants such as the gabapentin, the Neurons, the Lyricas, drugs like that. Next approach would be interventional methods like steroid epidural injections, as well as like facet block injections, things along of those natures as well. Period.
Should you just remind us what recommendation category A means? They strongly recommend this.
Yes. No. Category A means that it is recommended. Category A means that you that the evidence is there, but it's not that strong. And B is that it's not really based on all of the evidence. It's more of an expert opinion.
Okay. But the evidence for this is not strong based on what they're saying.
It's not strong.
So they're saying A is strong and evidence type is 3.
Right. It's not very strong.
Yeah.
The gist of all of this is that the guidelines are based on evidence that is not, it's not strong and there's not a lot of it, is kind of the take home. But it's still, they're still putting these guidelines out there to be followed. So if you don't follow it, it's kind of like you better have a good reason, kind of a thing. But they concede that it's not very strong with regards to the type of evidence and the category of the recommendations. So that was recommendation number 1. 2, before starting opiate therapy for chronic pain, clinicians should establish treatment goals with all patients, including realistic goals for pain and function. Consider how opiate therapy will be discontinued if benefits do not outweigh the risks. And clinicians should continue opiate therapy only if there's clinically meaningful improvement in pain and function. So I think this is like a kind of a good, strong point. And we do use this, but I think it's a little underused in the sense that we have to make it clear, it's on the clinician to make it clear to the patient as far as what are the goals of function improvement and pain improvement. The CDC encourages use of the PEG scale, where you talk about how much have you improved with your functionality and your pain since you've been on opiates. And clinically meaningful improvement is 30%. So if you can achieve 30% of improvement of functionality and pain symptoms with your regimen of pain medications, that's considered meaningful, and that is something that would be like validated. But if they're not getting to 30%, then the evidence doesn't show that they will ever improve with opiate management.
So if a patient has chronic pain and they continue on medical management with opioids, so per these guidelines, they shouldn't continue with medical management?
No, you can continue it if they're seeing if you're seeing clinical improvement. So if they say, like, let's say you start them on some opiate medications after your first visit.
Right.
Within a month to 2 months or 3 months, they're saying, Doc, I'm functioning a lot better. Their pain score was 7 when they first came in, and now it's 4. There's evidence that this was okay, and it is helping them to...
And they can continue.
And they can continue.
Is that an indefinite continue, or is it...
They can continue as long as they maintain that function. but and I'll get into other slides, is generally very, it's very apparent within the first few weeks and months whether or not this patient is going to benefit from opiate therapy or not.
The problem, though, is that, again, if they're not benefiting, are you going to increase the pain medications or say it's not benefiting, get out?
That's the issue.
Right.
So the evidence suggests that, escalating up, and I'll get again into a later slide, beyond a certain amount of morphine equivalents, that they're probably not going to get much benefit. Recommendation number 3: before starting and periodically during opiate therapy, clinicians should discuss with patients known risks and realistic benefits of opiate therapy and patient and clinician responsibilities managing therapy. Just 1 second. So this is kind of similar to what I just said. A few points here. Again, it's a little bit repetitive. Be explicit and realistic about expected benefits of opiates. Advise patients about serious adverse effects of opiates, including potentially life-threatening respiratory depression and lifelong opiate use disorder. Advise patients about the common side effects, which are less serious, such as constipation, nausea, vomiting, drowsiness, confusion, things like that. Discuss that opiates might have an ability to impair you for motor vehicle usage. And that's essentially the ones that I haven't touched on already. Number 4 of 12, when starting opiate therapy for chronic pain, clinicians should prescribe immediate release opiates instead of extended release or long-acting opioids. So this is, Dr. Rampersad talked about, this is a little bit of a departure from before, where it was after a while you were supposed to start them on long-acting. Now they're more kind of saying that if possible, if patient is getting that benefit, like the 30% that I talked about, you don't have to transition them to a longer-acting opiate. If they're benefiting, you can keep them on the short-acting opiate as they have less consequences and side effects in the long term, less chance of respiratory depression, less evidence that shows that they overdose when you're on short-acting as compared to long-acting.
And this is in contrast to what a lot of the insurance companies would recommend. Because they'll push you to change your recommendations to the patient from the immediate release to the long-acting, which gives a contrast.
Incidentally, just a couple of facts. Methadone, it causes cardiac distortion. Basically, it's the number one long-acting opiate medication which causes overdose. It's disproportionate because I think it's only like 1 or 2% of the amount of opiates that are prescribed, but it's responsible for 30 or 40% of the actual overdoses. Fentanyl patches are also implicated in high amounts of overdose because primary care physicians, they struggle sometimes because it's the way it's dosed in the patch is micrograms per hour rather than milligrams, so they get confused with like switching doses and patients get overdosed. Recommendation number 5. So this is kind of like the big one, I think. When opiates are started, clinicians should prescribe the lowest effective dosage. Clinicians should use caution prescribing opioids at any dosage. Should carefully reassess evidence of individual benefits and risks when considering increasing dosage to more than 50 morphine milligram equivalents per day. And should avoid increasing dosage to more than 90 morphine milligram equivalents per day, or there must be a careful justification or decision to titrate it above that level. So again, like I mentioned in the beginning, the evidence is weak that if you get above 50 morphine milligram equivalents, that they're actually going to benefit. So this is kind of like the point that they harp on, like multiple times throughout the guidelines, that 50 is kind of your mark. So like if a patient, again, so morphine equivalents, they're on like Q4 to 6 hours of Norco a day. That is acceptable if they're gaining function and they're improving. But going beyond that, when there isn't a real cause, like they're not post-op, or they haven't just suffered some sort of traumatic injury, or they're not, something acute is not going on, going above that requires significant justification and documentation as to why you think that they would improve by going over that number, is the take-home from that. If a patient's opiate dosage, for all sources of the opiate medications, if you do have to in fact increase over to 50 for whatever reasons, they do recommend more increased frequency of follow-ups. Okay, recommendation number 6. Long-term opiate use often begins with the treatment of acute pain. We see this every day. When opiates are used for acute pain, clinicians should prescribe the lowest effective dose of immediate release opiates and should prescribe no greater quantity than needed for the expected duration of pain severe enough to require the opiates. 3 days or less will often be sufficient. More than 7 days will rarely be needed. This is pretty self-explanatory. 7, clinicians should evaluate the benefits and harms with patients within 1 to 4 weeks of starting opiate therapy for chronic pain or dose escalation. Clinicians should evaluate benefits and harms of continued therapy with patients every 3 months or more so. If benefits don't outweigh the harms of continued opiate therapy, clinicians should optimize other therapies and work with patients to taper opiates to lower dosage and then discontinue. So, experts noted that risks for opiate overdoses are greatest within the first 3 to 7 days after you start opiate therapy or after you increase a dosage of medication. So if a patient, let's say, comes in post-operatively and they were on Norco prior to surgery and now they're on, let's say, we put them on Dilaudid because there's increased pain. They recommend, just like I noted before, within a week, they should come back in if you're starting them on a new opiate or you're increasing them because that's when the vast majority of overdoses take place, within 3 to 7 days. So that's critical for us moving forward, and that's basically what we've been essentially doing. We're having 1-week follow-ups when there's been an escalation in dose or a change in the medication. When opiates are reduced or discontinued, the taper should be slow enough to minimize the symptoms and signs of opiate withdrawal, such as drug craving, anxiety, insomnia, abdominal pain, vomiting, diarrhea, diaphoresis, to mention a few. The decrease should be approximately 10% per week, and this will ensure a more steady and stable decrease. But because, again, in the tapering phase is also a very critical point where patients overdose because they try to do other things to try to manage this like instability. Number 8, before starting and periodically during continuation of opiate therapy, clinicians should evaluate the risk factors for opiate-related harms. Clinicians should incorporate into the management plan strategies to mitigate risk, including considering offering naloxone. When factors that increase risk for opiate overdose, such as a history of overdose, history of substance use disorder, higher opiate dosages more than or equal to 50 morphine milligram equivalents, or concurrent benzodiazepine usage. So they name off some high-risk kind of groups of patients that you need to really have some strong consideration in before starting opiates. Again, this is not that you can't start opiates, but this is the groups that you need to exercise caution. So patients with sleep disordered breathing, such as sleep apnea, they state that you must exercise caution with mild sleep apnea, mild sleep disordered breathing. However, if they're on CPAP, which is considered moderate or severe, you should really try to avoid it if possible. Pregnant women, if you're going to prescribe for pregnant women who have been on chronic opiates, the absolute minimum effective dose needs to be used for pregnant women. Studies now are showing that women on opiates while pregnant are associated with stillbirths, poor fetal growth, preterm delivery, as well as birth defects such as cleft palate. They recommend if there's an opiate abuse problem for these women, they should be going to assisted therapy with buprenorphine or methadone clinics just for the pregnancy, and this improves outcomes. There's clinical evidence for that as well. Of note, codeine should be avoided completely. It's not even at all costs. It should not be given in pregnant women because it's associated with neonatal toxicity and death for the newborn.
Codeine?
Codeine.
So we used to give that left and right for pregnancy.
Really? Yeah, I hadn't heard that. I wasn't aware of that until I read this guideline, actually. Patients with renal or hepatic insufficiency are obviously, you need to be cautious because they have less clearance of the drug, less metabolism of the drug, so plasma levels of the drugs will be accumulated and be higher, and they can suffer side effects, obviously. Patients over 65, again, these patients, as you get older, even without like documented renal or hepatic disease, metabolism, kidney function, things like that slow down, and again, you're at risk for accumulation of drug, respiratory depression, death. Patients with mental health disorders, including depression, anxiety, PTSD. Obviously, patients with substance abuse disorders, illicit drugs, and alcohol are listed as factors on a very significant portion of the death certificates for patients who overdose on opiates. Patients who have suffered a non-fatal overdose, And another thing that they suggest multiple times throughout the guidelines is offering naloxone to patients with dosages higher than 50 milligram equivalents. We'll get into that at the end of the slides.
So we're calling 50 morphine equivalents a higher dose.
Yeah.
Is there a consensus on? So let's say you have a patient. This is an initial encounter, chronic pain. Where do you start? Is there any?
So that's a good question. I mean, it's you're supposed to start with non-opiate management. So you're supposed to start with the NSAIDs, your acetaminophen, go to physical therapy, cognitive behavioral therapy. And it's not necessarily like it has to be in a sequential order like that, because a lot of these patients that come to us have tried these measures before, but that's the guideline. That's what you're supposed to follow. Now, if you get a patient who's been on 100 morphine equivalents a day for 30 years, you're not going to give them some Tylenol. But you're going to, that's the guideline. And when they come in, you're supposed to try to taper them down off of that 100 while using these other methods.
Right. Because we, in the context of, we have a threshold of pain control that we're trying to reach to say, is this efficacious or not?
Right.
So that it seems that there would be kind of a baseline level at which you would start.
That's kind of what we were hoping for with these guidelines, actually, but
there isn't, and I mean it's going to be based on different people's metabolisms.
Yeah.
it's basically going to be clinical judgment.
There's a threshold in terms of the maximum.
Sure.
But as far as the initial start, it's kind of up to the clinician. Generally we try to start people on something like Tramadol initially. Then you get people who complain that they're allergic to it. So then we'll try maybe 5 milligrams of Norco. And that's in somebody who's opiate naive. You know what I mean?
Right.
But other than that, it's more the upper threshold. There's no real lower threshold, and there's no real lower starting point, unfortunately.
Right. So these guidelines are just based upon like the dangers and risks that can occur above a certain number, and then they kind of put the number at this is probably your best bet as like a ceiling. Okay, so number 9, clinicians should review the patient's history of controlled substance prescriptions using state prescription drug monitoring program. That's our MAPS in Michigan. Data to determine whether the patient is receiving opiate dosages or dangerous combinations that put him or her at a high risk for overdose. Clinicians should review PDMP data when starting opiate therapy for chronic pain and periodically during opiate therapy for chronic pain, ranging from every prescription to every 3 months. Pretty self-explanatory. Look at the maps. See if they're getting medications from multiple providers. See if they're getting other harmful medications in combinations such as benzodiazepines, things like that.
And then you're putting it into the chart.
And you put it in the chart, absolutely, yep.
Because they change, like the next day you can do it, and it'll change because they didn't update it in time.
Right, yeah, that happens too.
That
Because sometimes it
happens.
takes like 7 or 8 days for them to
Right,
actually
right.
update the maps.
That way you can record that this is what I saw, this is what I went by.
Exactly, yep. 10 of 12, when prescribing opiates for chronic pain, clinicians should use urine drug testing before starting opiate therapy and consider urine drug testing at least annually to assess for prescribed medication as well as controlled prescription drugs and illicit drugs. So with this, again, it's pretty self-explanatory. Clinicians should use unexpected results to improve patient safety. That's the bottom line. Tapering or discontinuation of opiates, more frequent reevaluation, offering naloxone. These are all the things that must be taken on if you see something in a urine drug screen, such as an illicit drug or other medications that are not being prescribed to them by per their maps. These are things that you need to bring up with them and ask them, is there something else going on, and then refer them, not necessarily get away, but to refer them to an addictionologist if they're open to going there, and then initiating a slow week by week taper to discontinue the opiates. So this is probably, I would say, like the second biggest point. The first one was the 50 milligram equivalents. This for our clinic here, number 11, clinicians should avoid prescribing opiate pain medication and benzodiazepines concurrently whenever it's possible. So contextual evidence review found that there is evidence to support that a large portion of opiate overdoses are associated with benzodiazepines. 4-fold increase, 4 times the amount of overdoses when you are concurrently prescribed a benzo. experts agree that although there are circumstances when it may be appropriate to prescribe opiates with benzos, like if they've been on a stable dose of opiates, let's say like 0.5 milligrams of Xanax for 3 or 4 years, and it hasn't changed and it's been stable, at that time it's a lower risk than with someone who is just acutely starting benzodiazepines or someone who's been on an escalating dose of benzos. There is there's a greater risk of a harmful overdose with benzos than there is with opiates. It can lead to seizures and even death, which is not the case with opiates. So if you're going to start a taper for both, you should start with the benzodiazepines. A commonly used tapering schedule, which is what is basically approved by the CDC, is a 25% reduction in benzodiazepine doses every 1 to 2 weeks in association with CBT, which I noted earlier, the cognitive behavioral therapy. And the last one is clinicians they didn't really want to get into the addiction aspect of it. This is more for prescribing for patients who are using opiates. Clinicians should offer or arrange evidence-based treatment, usually medication-assisted treatment with buprenorphine or methadone in combination with behavioral therapies for patients with addiction issues. So there was one thing about that I think could be relevant is physicians who are not certified to provide buprenorphine in an office setting can receive a waiver from the Substance Abuse and Mental Health Services Administration if that's something that they wanted to do, or if that's something that we wanted to do here. So that's essentially it. Some conclusions and take-home points. There was a rebuttal letter of sorts from the American Academy of Pain Medicine, and of course, it was very easy to point out that all of these recommendations are based on evidence type 3 and 4, which is poor. And they thought in the letter, they kind of made a couple of statements that thought that maybe the CDC was being a little bit kind of disingenuous with some of their phrasing. So they have revised it a little bit, even since I've read it over the weekend. But it's still basically the same. They haven't changed too much. Again, the 50 milligram morphine equivalents, multi-modal therapy, they say that multiple times over and over again. CBT, physical therapy, is huge when it comes to prescribing opiates. PEG scale, I think this is something that's great. The 30%, we should talk to the patient, make sure that what they're conveying to us is actually what they're achieving as far as functionality and pain relief. Because a lot of times, when you're not clear and you're not specific, and you ask, so what is your worst your pain has been over the last month? A 10. What is your average pain? A 10. What is your pain right now? A 10. So when you ask them, but if you're using the narcotics, if you're using the Norco, is it helping at all? They'll say yes. So it's imperative on us to document that, in fact, they are having benefit, and they're having substantial benefit when they're on opiates, and to document that. Benzodiazepines, like I said, extreme caution, no more than 1 milligram per day, and only with short-acting opiates. More frequent follow-ups, which we do a good job of, and again, pregnancy was also a huge one, and we've discussed that as well, potentially having a conjunction with Sacred Heart. Thank you.